Hi, Medical English. My topic is a randomized trial of the protocol-based care for early septic shock. Definition. Sepsis is a clinical syndrome of the potentially lethal organ dysfunction caused by dysregulatory response to infection. In a septic shock, there is a critical reduction in the tissue perfusion. The acute multi-organ failure might occur, affecting the lungs and the kidney and liver. The most common cause in the immunocompetent patient include many different species of gram-positive and gram-negative bacteria. These include the fever, hypotension, oliguria, and confusion, and diagnosis is the primary clinical convey the which culture result. The showing infection, the early recognition, and the treatment are essential.
Sepsis is a life-threatening clinical syndrome that develops when the body's response to infection injures its own tissues and organs. Clinical criteria for diagnosing sepsis were first proposed in 1991 and last updated in 2001, but a lot has happened since. So now, a task force of critical care, infectious disease, surgical and pulmonary specialists has published the third international consensus definitions for sepsis and septic shock that take advantage of advances in the science of sepsis and the ability to test proposed sepsis criteria against patient outcomes using electronic health records data. The group defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. In clinical terms, patients with sepsis have suspected or documented infection and an acute change in the sepsis-related organ failure assessment or SOFA score of greater than or equal to 2. The group recommends use of a bedside score, the Quick SOFA or Q SOFA score, comprising an increased respiratory rate, alterations in cognition, and low blood pressure, to identify patients outside critical care settings with suspected infection likely to have poor outcomes typical of sepsis. Finally, they define septic shock as sepsis with abnormalities in circulatory physiology and cellular metabolism in the absence of hypovolemia, profound enough to increase mortality. The authors acknowledge that there is no reference standard for diagnosing sepsis and that the definition of sepsis is and should remain a work in progress.
Application in medicine. In a single center study published more than a few years ago involving the patient presenting to the emergency department with severe sepsis and septic shock, the mortality was markedly lower among those treated according to a 6-hour early directed therapy (HDT) protocol, in which intravenous fluids, the vasopressor inotropic, and the blood transfusion, they were treated to the achieved central hemodynamic target than amongst those receiving usual care. Pros and cons. Pros. The protocol for HDT calls for central venous catheterization to monitor central venous pressure and the central venous oxygen saturation, which were used to the guided use of the intravenous line, the fluid vasopressor, concentrated red blood, the central transfusion, and the dobutamine to achieve specific physiologic goals. Crystalloids were the predominant fluid used in our works, administered in 96% of patients the overall. There were no significant interaction between the acids, the treatment. Cons. Our study the protocol specific threshold for vasopressor use the book note the specific choice of the vasopressor. The protocol guided only reduction and the with all other aspects of care, including the choice of antimicrobial agents and the discretion of the treating physician. Issue applied in Ecuador. In a study conducted in the intensive care unit of the Hospital General Enrique Garces, the purpose of the study was to evaluate the capacity interleukin 6 as predicted the biomarker of the mortality in patients in the weak sepsis in the intensive care unit. It was found that interleukin 6 is able to predict survival, which 17.3% the patient the surviving versus 29.7% the patient dying, and that a rapid decrease of the interleukin 6 in the first 14 hours could be a useful tool for the successful antimicrobial therapy.
The medical team in this intensive care unit at Mayo Clinic is on high alert 24/7, watching for signs of sepsis.
Sepsis is a potentially life-threatening complication related to an infection.
Dr. Canon Ramar says every year close to 750,000 people in the U.S. develop a septic reaction. It happens when an infection prompts the immune system to kick into overdrive, causing problems such as kidney failure, liver failure, severe drops in blood pressure, and even death.
It becomes very important that this is recognized early.
That's because the death rate can be very high, up to 75% for people who develop sepsis at home and up to 25% for those who get it in the hospital.
It's almost similar to treating a heart attack or a stroke, where you have a very short window.
That window is 6 hours. Dr. Ramar's team uses what are called sepsis sniffers, technology that monitors things like fever, heart rate, and blood pressure, and alerts the medical team when a patient's in danger.
Okay, I think let's go ahead and activate the sepsis response team.
We have a patient in room number 20. We want to activate the SRT.
If blood tests confirm that's true, the septic response team launches into action.
It's a big multidisciplinary approach to do this. And so all members of the ICU team are actively involved to get this aggressive resuscitation going and to get all things done within that 6-hour window period. Let's get the central line ready.
We did give a dose down in the ED, so continue with that.
We follow what we call as the surviving sepsis resuscitation guidelines.
Methods of best practice developed by the Society of Critical Care Medicine to ensure the best possible treatment for patients.
If the necessary things are done, then the mortality drops down dramatically.
Sniffing out sepsis and saving lives. For Mayo Clinic News Network, I'm Vivian Williams.
Conclusion. In summary, in the our multicenter randomized trial is the which patients that were identified early in the emergency department with septic shock and they reside immediately in antibiotic and the other aspect of non-resuscitative care, we found no significant advantages with respect to mortalities or morbidity of the protocol. The vaccine care by resuscitation provided and the discretion of the treating physician. Thanks.